Very good afternoon to all my seniors and my dear friends. At the outset, I would like to thank Dr. Shyam Agarwal sir and the organizing team for this opportunity. My mandate for today is perforator flaps for breast reconstruction. I'm an oncoplastic breast surgeon, so I'm going to talk only about partial breast reconstruction by using perforator flaps. So at the outset, I would like to discuss why perforator flaps are actually needed in the armamentarium of an oncoplastic breast surgeon. We all know that breast conservation surgery in a suitably selected patients actually offers better cosmetic outcome and equivalent survival as well as good quality of life. We know that for achieving good cosmetic outcome, we need to use breast volume displacement or replacement techniques. And in small to moderate breasts with larger tumors, sometimes we are at a loss to use some volume replacement therapy, volume replacement technique. So far, for last many years, LD flap has been a workhorse for volume replacement in such patients with small to moderate breasts and larger tumors. Later on, we started using mini LD. However, with the use of LD flap and mini LD, there used to be a significant morbidity and loss of muscle function. At the same time, with the better understanding of the anatomy of the intercostal vessels, the plastic surgeons actually evolved the muscle sparing flaps, and these flaps then were incorporated into the armamentarium of an oncoplastic surgeon with the aim of reducing donor site morbidity and better aesthetic outcome. So what is a perforator flap? It is a flap, it is an island of tissue which is consisting of skin and subcutaneous tissue which is perfused by an isolated artery and a vein which perforates the deep tissues, that is either a muscle or a fascia. And the perforator flaps are actually named after the source vessels. You've seen that the perforator flaps have actually evolved from the random pattern flaps which were pioneered in the late 20th century, which then were converted into or were adapted in the form of musculocutaneous flaps and fasciocutaneous flaps. However, till the later part of the 20th century, till we could not understand the vascular anatomy of the flap, there used to be many flap failures. And as a result, when the perforator technique or the concept evolved, perforator flaps were actually devised, and these were incorporated into the oncoplastic breast techniques. It was realized that there were many perforators in and around the periphery of the breast which could be utilized for developing these perforator flaps and for replacing the volume lost after tumor resection in breast. So in the early part of 21st century, there was a conference in Ghent which was actually based on the perforator technology, and it was the perforators were classified into 5 different types based on their whether they are perforating the fascia or whether they are perforating the muscle and then reaching the skin, or whether they are perforating the intermuscular septum. So the perforator flaps are based on mainly the angiosome and perforasome theory. So an angiosome is a territory of tissue supplied by a common source artery, and among these angiosomes, a perforasome is a very special tissue which is actually a unique vascular region supplied by a single perforator. And now we'll see how these perforator flaps are used in breast surgery. These breast perforator flaps are used in multiple ways, either for reconstruction of after BCS, the partial breast defects can be reconstructed, or after mastectomy for breast reconstruction, either alone or with the help of a implant. And again, for correction of post BCS deformities, these perforator flaps are very useful. So either they can be used in the form of a free flap especially for post-mastectomy breast reconstruction, or in the form of pedicle flap, which is the commonest way the perforator flaps are used in today's times, and propeller flap when we need to replace the skin and we want the flap to be mobilized at a distance. The pedicle of the perforator flap is actually skeletonized and can be used at a distance from the source or the donor area. So for partial breast reconstruction, Many flaps have been actually devised, and the commonest flaps which are actually used in today's times for partial breast reconstruction are the intercostal artery perforator flaps. These flaps have been actually first described for the use of partial breast reconstruction by Mustafa Hamdi et al. Now let us see how these perforator flaps are actually selected for reconstruction. It all depends on the breast tumor ratio, and the most important thing is location of the tumor. So whether the tumor is located in the lateral quadrant or medial quadrant or inferior quadrant of the breast, the choice of perforator flap actually varies. So TDAP flap is actually utilized or is useful for most of the quadrants, excluding the upper or extreme medial quadrants. Then for lateral quadrants and the lower pole tumors, the LICAP and the LTAP flaps are used. And for medial and inferior quadrant tumors, either anterior intercostal artery perforator flap or superior epigastric artery perforator flap or medial MICAP, these can be used. There is an overlap of the area which can be covered by these flaps. However, we have to choose the most suitable flap which will have a good reach without any tension at the donor area. So this diagram shows the location of the perforators, as you can see here, and based on the location of the perforators and the location of the tumor, whether the flap will easily reach to that area, the perforator flap is selected. So what are the suitable candidates for perforator flap surgery? Basically, small to medium breasts with larger tumors, and the patients who have either no ptosis or mild ptosis. These are the ideal candidates for selection for perforator flaps. And especially so if there is a loss of more than 20% of the breast volume after resection of the tumor. And the other prerequisite for selecting reconstruction with perforator flap is that the patient should have sufficient laxity of skin either at the lateral or inferior part of the breast, so that the flap can be harvested and the donor area can be primarily closed. So these flaps are suitable for most of the tumor locations based on the location and the availability of the perforator in that area. So what is the pre-operative planning? The most important thing is to do a pre-operative perforator mapping. In case if the patient has a lateral tumor and if the patient has had previous surgery or there is an extensive scarring in the lateral chest wall, then probably the perforators may not be available for flap harvesting. So a pre-operative perforator mapping is very, very important. And for that, a handheld Doppler device is good enough. Usually CT scan is not done on a regular basis, but in case if there is a doubt about the perforator availability, then occasionally CT scan may be required. Then ideally the preoperative marking should be done 1 day prior, so that we are well prepared to operate on the patient and we do not hesitate or we do not jumble on the surgical planning. Then there are two parts of the preoperative marking. One is to mark the incision through which the tumor can be easily resected, and the other is to mark the donor area. So both the markings have to be done to get best access to the resection as well as to achieve a best aesthetic result at the end of the surgery. And for marking the flap donor area, the marking should be done in such a way that the donor flap actually reaches the defect in a very convenient manner, and we can achieve primary closure without any tension in the donor area. And of course, the donor area aesthetic result is also equally important. Most of these patients can be actually treated or operated upon by placing the patient on OR table in a supine position, except for some cases wherein a long TDAP flap is required, where after the resection of the tumor, the patients may have to be turned into a lateral decubitus position. Otherwise, a supine position with a pillow under the shoulder and abducted arm is good enough for harvesting these flaps. So I'll talk in detail about intercostal artery perforators. These intercostal artery perforators are the branches of posterior and anterior intercostal arteries, and they form an arcade between the aorta posteriorly as well as the internal mammary artery anteriorly. And this arcade is divided into vertebral, coastal, and muscular segments. And these perforators actually arise from dorsal and vertebral, coastal, or muscular segments, which can be utilized for development of these flaps. Let us talk about LICAP flap. LICAP is the lateral intercostal artery perforator flap. Is suitable for, again, small to moderate non-ptotic breasts, and suitable for laterally placed tumors, especially from 1 to 4 o'clock position, or 1 to 5 o'clock position on left side, and from 5 o'clock to 11 o'clock position on the right side. Again, sufficient lateral chest wall laxity is important. If a large flap is designed with a good perforator, then the LICAP flap is actually able to replace nearly 50% of the breast volume. However, in majority of the patient, this is not required. In case if the tumor is large, then usually we either tend to use neoadjuvant chemotherapy or some other technique is actually utilized. These LICAP flap perforators are actually easy to locate, and they are of good caliber. And the other advantage is that the donor scar, although it is long sometimes, but it can be very well hidden under the bra line. It's a fasciocutaneous flap and is based on perforating branches of coastal segment of lateral intercostal arteries. However, the pedicle length is short. It is only 3 to 4 centimeter, and that too when you are actually properly dissecting the perforators. And that is the reason the reach of the flap is not very large compared to the LTAP flap. So, and these perforators are actually located from the anterior border of the LD vessel at the distance of 2.6 to 3.4 centimeter. And there is, in most of the patient, there is a dominant perforator which is found in the 4 to 8 space, which actually communicates with the thoracodorsal or serratus anterior vessels. So these are the some of the cases which I had operated along with my colleague, and there are other cases which have been actually taken from the internet. For inserting the LICAP flap, whether you are you need the skin to be replaced or not, it depends on that whether you are actually utilizing this as a propeller flap where you skeletonize the perforator and increase the reach, or whether the defect is very close to the donor area wherein you can just flip the flap into the donor defect where probably you may not require to skeletonize the perforator. Then there is a modification of LICAP flap which has been actually suggested by Maybody et al. Which the flap orientation is in a vertically oblique manner so that a transverse long scar can be avoided, and from the superior aspect of the scar, you can access the axilla, and from the anterior aspect, you can access the laterally placed tumors. So again, a very good modification and suitable for patients who are in the lateral quadrant. These are some of the examples. Then MICAP is again located in the medial aspect of the breast. Easy to locate, consistent perforator location, good caliber vessels, and suitable for tumor locations in the medial aspect. Another example, again, MICAP has been used to replace the large tumors in the inferior quadrant with the skin replacement as well. This is pre and post-op. Again, MICAP skin replacement can be very well achieved. Then anterior intercostal artery perforator flap suitable for inferior pole tumors located between 5 to 7 o'clock position. The perforators are located around the 6 o'clock position below IMF. Pedicle length is limited. However, they can be actually flipped or folded into the defect situated in the inferior quadrant. In both MICAP and ICAP, you need to recreate the internal inframammary fold. Scar can be very well hidden under the inframammary fold. These are some of the examples. Then post-BCS deformity can be very well corrected by using ICAP, as this can be shown in this picture. Then lateral thoracic artery perforator flap, suitable for again moderate to small size breast. Lateral defects can be used in combination with LICAP, However, sometimes in nearly 25% of the patients, the perforators may be inconsistent, and you should always have a plan B in case if you do not find the perforator. And they are actually useful in combination with LICAP for replacement of a large resection volume. These are actually larger caliber vessels compared to the LICAP vessels and have more flexibility and wider reach. Again, a picture showing lateral thoracic perforator flap. Advantages, they actually, because of the larger caliber, and you can actually replace a large volume of tissue, as you can see here. Then TDAP is a thoracic dorsal artery, has two branches, and both branches give multiple perforators. And because of these multiple perforators, the flap can be harvested either horizontally or longitudinally or in a bilobed fashion. And it can be harvested with a large skin paddle of around 14 into 25 centimeter. And if the perforators can be dissected to the source, then the pedicle length can be achieved to 14 to 18 centimeters. And as a result of that, these flaps are actually suitable for all the locations except for maybe extreme medial locations. Again, these are some of the examples. So TDAP is an actually alternative to latissimus dorsi flap. And because LD muscle is spared, it leads to less morbidity, muscle is spared, reaches all quadrants. However, it is technically challenging and you have to be very, very careful while dissecting the pedicle through the muscle. So these are other flaps. I'm not going to talk about the post-mastectomy. So to conclude, I would like to say that perforator flaps are very much here to stay in the oncoplastic breast surgery surgeons armamentarium. They have less donor site morbidity, less seroma, less contour deformity, and faster recovery. Because the muscle is not utilized, there is preservation of muscle function, and they have reliable blood supply, and they can be actually filled with breast-like tissue, skin island also can be replaced. And the most important thing is does not lead to asymmetry. So because of the use of perforator flaps, we do not need to do any contralateral symmetrization procedure. Although the scars are long, but over the time they fade and they are very well accepted. With this, I would like to thank you.